Hi, I'm Dr. Joanne Smith.
And I'm Dr. Corinna Hankins.
And this is
A Podful of Pediatrics.
Subscribe here for more content.
Or go to onecommunityhealth.org.
Or follow us at One Community Gorge. And this is the one where we talk about
tuberculosis.
That's like actually a fun word to say.
It
I
is.
never really thought about
Not
that
a fun
before.
disease,
And
totally a fun word to
tubers
say.
are potatoes. I wonder if that's related. Maybe that's where it came from. So tuberculosis is caused by a bacterium called Mycobacterium tuberculosis.
And when a person breathes in tuberculosis particles, the particles basically can settle in the lungs and then grow. And from there, they can actually move through the blood to other parts of the body, such as kidney, spine, and brain. So while everybody thinks of tuberculosis as this kind of coughing, really lung-based disease, there's actually other types of tuberculosis. And interestingly, those are more common in children.
And TB, it can live in your body without actually making you sick. It can be inactive, or what we call latent TB.
And these people do not feel sick. They do not have symptoms of tuberculosis, and they cannot spread tuberculosis to others. It just kind of sits there.
But the problem, if you don't treat the inactive TB, it can actually wake up and become active at any time and then make you be really sick.
Yeah, and it typically is worse in people with weakened immune systems, or somebody who develops a weakened immune system, like from HIV or immunosuppression, for taking medicines that make them immunosuppressed. All of those can be high risk for developing active tuberculosis. Those particles really become kind of start to spread.
So CDC estimates up to 13 million people in the U.S. live with latent TB or inactive TB.
And without treatment, 1 in 10 people with inactive TB will actually develop active TB.
And if you have active TB of the lung or throat, you need to be treated. Otherwise, you'll start spreading it to a lot of other people.
So active TB does spread. Inactive TB does not.
Yes. And without treatment, active TB can be fatal, especially in children.
That's right. So what is the history of TB? And human TB, truly is ancient.
Right. Thousands of years it's been documented, 9,000 years. Ancient Egyptian mummies showed spinal TB on their little, what are those called? The murals on the wall?
Yeah.
I can't remember the name.
Like pictographs, right?
Hieroglyphics. That's the language anyway. Anyway, there were mummies with spinal TB.
That's right. And Hippocrates, the Greek physician, describes symptoms of TB around 400 BC.
And for centuries, TB was called consumption because it seemed to eat the body away.
That's right. It just consumed the body slowly, and the disease peaked really during the Industrial Revolution, really due to crowded cities and really poor living conditions.
Yes. And in 1882, Dr. Robert Koch discovered the bacteria, Mycobacterium tuberculosis, and he confirmed that TB was infectious.
What's fascinating to me is that they actually, even back in the time of Hippocrates and those, when they were describing the symptoms, soon after that, they actually identified that there was probably this microorganism. They didn't say microorganism. They just said really, really tiny.
Words, yeah.
Right? They didn't say that yet. That was causing this TB and how it was spreading. And they just looked at how TB spread and kind of determined that. So it's really actually a fascinating disease because it's had such a long history. And the determination of what it was involves such a long history.
And so the breakthroughs came when a vaccine was developed in the 1920s, and then when they found or created actually antibiotics that could treat it, because it used to be a death sentence. Consumption literally would consume you.
Active TB consumed you.
And now it has become a treatable disease, though it remains really challenging globally.
Right. No country, and this is really important, no country is TB free. And the disease is endemic in most poor countries of the world, meaning in most poor or developing countries, they do still have a significant amount of both latent and active TB.
And it's estimated that 1/3 of the current global population has latent TB.
1/3.
1/3 of the global population.
A huge amount.
And when we talked about the U.S. has about 13 million, which I can't do that math, but it's not close to 1/3.
That's right. And of that 1/3 of the population who asymptomatically have TB, 5 to 10% of those will develop clinical or active TB within their lifetime.
In 2001, I don't know why this is the most recent World Health Organization estimates. There were 60 to 20 million cases of active TB worldwide, with more than 8 million new cases annually and 1.8 million deaths each year.
And often, most new cases and deaths occur really in developing countries where infection is acquired in childhood.
Which is why we're talking about this, because globally, this is really a pediatric disease.
Right. The annual risk of TB infection in high burden countries, meaning those countries in which it's endemic, is estimated at 0.5 to 2%. Childhood deaths from TB are usually caused by, interestingly, not the pulmonary part, but meningitis or disseminated disease.
Right. So, here we talk about TB as in terms of pulmonary TB in the U.S. It's a persistent cough lasting weeks, chest pain, coughing up blood is a classic, fatigue, weight loss is super common, fever, and night sweats.
And when TB spreads beyond the lungs, its symptoms can really vary. Spinal TB can just present as back pain and paralysis. Kidney TB can present as blood in the urine. Brain TB can trigger really severe headaches, and that could be the earliest.
And to diagnose TB, there's really two tests in the U.S., a skin test or a blood test. The skin test is the PPD, where you get a little needle and they make a little bubble in your skin. And most people in the first 24 hours are going to have like a little skin reaction to that. But 48 hours, it should be completely gone. They mess you up.
Sorry. And for active TB, you can do sputum, like basically just means they cough like this phlegm into a cup, and that you can actually culture it. But now one of the most common ways is really us doing like a swab and doing DNA,
and there is a blood test, but it's not completely accurate. There was definitely false positive with the blood test, so the more accurate way is to get the sputum culture or the
if we're worried about
DNA.
Active TB.
Exactly.
But a screening, the blood test for screening is really helpful. And often now they'll do that instead of the skin test all the time.
Yes. And TB, we talked about, is spread mostly from the coughing part, right? Which is why kids are not really spreading it, because we said they don't really get pulmonary disease. It's adults that typically will spread it. And they're big droplets that will kind of be released into the environment.
These droplets linger in poorly ventilated indoor spaces, and so often TB is really a disease that's spread in close contacts. It does not spread, interestingly, through touching, sharing food, kissing even, and typically factors like HIV, diabetes, smoking, malnutrition, any of those things that weaken the immune system really make it more easy either for latent TB to become active or people to get active TB in the first place. While it is a respiratory droplet, it is not as contagious as things like COVID
the
or
flu,
measles.
Or measles, for sure.
That's right.
So treatment is typically 4 antibiotics, and that is because over time TB has kind of become more resistant, and we know that this combination of these 4 antibiotics are how we need to treat it to completely clear it.
And really the way to kind of prevent TB from taking hold is, again, not just treating your active TB, which absolutely they will have to be treated, but and that will actually keep them from spreading it anymore as well, but also treating your latent TB, especially in people that are in high risk groups.
And the standard treatment is 6 months. There is some drug-resistant TB that actually requires 18 to 24 months of antibiotics. And in the U.S., we do something called directly observed therapy, which means that the healthcare worker comes to watch you take your medicine every day to make sure you're taking it, because people forget to take medicine.
That's right. And actually, this is one of the big wins and one of the big reasons why we have not as much TB in the United States today, is because public health in the United States, the development of health departments and people actually really paying attention and helping with these types of things changed this course for tuberculosis. So when we actually did this direct observed therapy and made sure that everybody with active tuberculosis was being treated for that entire
taking the medicine
6-month
every
period,
day for 6 months, right?
Right? We really decreased our rates of tuberculosis in the United States.
And it's not a combative thing. I mean, I've had families go through it. They're actually become like friends with them, like they're happy to see them every day. And it's a helpful reminder. Be like, oh my gosh, I didn't take it today. I got to take it.
But this was really a win for public health in the United States. This is one of the reasons why we have public health in the United States. We were able to really, again, we haven't eradicated tuberculosis because there's still a lot of latent tuberculosis out there, but we have made active tuberculosis very rare.
And there is a vaccine, right? We've talked about vaccines a lot. We've actually been through all the childhood vaccines. And so this is the one that we have not really addressed because of the good public health service. We haven't really needed to institute this vaccine in the U.S.
But there is a vaccine for tuberculosis that it's used very frequently in other countries, developing countries, and countries where it's endemic. And this is called the BCG vaccine, which was developed
because it was French, right? That's how you would say it.
Developed in 1921 by French scientists Albert Calmette and Camille Guérin. So Calmette and Guérin, BCG.
Yeah, and it was made from a weakened strain of a cattle TB strain, right? Kind of like the smallpox vaccine was cowpox. This was like a way to get your immune system to recognize it so it can react to it.
And while BCG reduces severe tuberculosis in children, it's actually less effective in adults. And this is another reason why we don't really use it in the United States. Once we actually were able to decrease that active TB, so the chance of adults giving it to children was really rare and not very common, we didn't need to use this vaccine that is really, really best for children and to prevent childhood TB.
So it's widely used in countries with a high level of endemic TB, like India and South Africa, to protect the babies.
Right. But it's less effective in adults. Recent trials have focused on boosting BCG with new vaccines, and there is now a protein-based vaccine, which they're using more in other countries as well.
Research is continuing to look for, is it worth doing universal TB vaccines, but so far, it doesn't make sense to do anything other than BCG in these endemic TB countries.
One of the reasons they don't love to do it in places like the United States where it's fairly uncommon is that it can have a potential to cause a false positive TB test, especially the skin test TB, right. If it's been given recently. And so sometimes that makes then diagnosing TB a little bit harder.
And, the BCG vaccine can make the kids feel pretty sick, some fever, some muscle aches, and then you get this swollen red area. And I would see it a lot in my patients who were from India, and they would take the baby over to meet the grandparents. And while they were there, they would get the vaccine.
Yeah, because kind of be in the shoulder.
It'd be in the shoulder right here.
Funny little scar.
Yeah, because it's safer for them when they visit to protect the child than not.
That's right. In the 100 years since its use, BCG vaccine, especially in these countries where it's endemic, has prevented countless deaths from children or from tuberculosis, especially in children.
And so it's a global health threat, not that big a deal in the U.S., but recently there was an outbreak.
That's right. There was.
And
actually,
intermittently, there will be outbreaks here.
That's right. This one's actually interesting because it was in February in 2026, and it was actually in a high school in San Francisco that temporarily had to close because there were so many cases of tuberculosis in that high school.
And it's under control because, again, a good public health response, right? So they tested 96%, which was 1,359 people of the school community. And of those, 207 had been confirmed as having latent TB, 4 confirmed and 3 suspected active TB.
Okay. And those TB really might seem like a disease of the past in the United States, but this outbreak is a kind of a reminder that in fact, if you just take California, more than 2 million Californians have latent TB. And what they suspect happened in this outbreak was that there was latent TB already there, kind of in the population. And for some reason it became active, whether someone became immunosuppressed or whatever happened. Mm-hmm. And then it spread within that small community because there was a really tight-knit community.
Yeah, because high schools, they all hang out together a lot, right? A lot of close time there.
That's right.
But they said the public health department responded, tested everyone, got the people with active TB treatment, got the people with latent TB treatment to really get this out of control so it didn't leave the high school.
That's right.
It wasn't like San Francisco was taken down.
It was in that small community. They were able to confine it, treat it, and this is again a public health win. And one of the reasons why we don't have to vaccinate everybody in the United States, because we have treatment that works really well at keeping your children safe, happy, and healthy.
That's for sure.
And free of TB.
Exactly. And so I'm Dr. Joanne Smith.
And I'm Dr. Corinna Hankins.
And this is A Podful of Pediatrics. Thanks for listening.
Thank you.